Hello and welcome to today's Center for Healthcare Strategies webinar made possible by the DentaQuest Foundation on a framework for advancing oral health equity. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's presentation. There will be 3 question and answer sessions during today's event. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. I will now turn the webinar over to June Glover, Program Officer at the Center for Healthcare Strategies.
Hi everyone, and welcome again to our webinar, A Framework for Advancing Oral Health Equity. This is June Glover, Program Officer at CHCS. The aim of today's webinar, as the title suggests, is to introduce a framework for advancing oral health equity. We'll begin with a welcome and introductions of today's presenters, followed by an overview of oral health equity. Then I'll turn it over to North Carolina Oral Health Collaborative and Connecticut Oral Health Initiative to give us their perspectives from the field. Lastly, we'll wrap with a few minutes for questions and answers. Zuleika Santiago is the director of the North Carolina Oral Health Collaborative, an organization that brings together partners across the state to address oral health equity. Prior to joining the collaborative, Zuleika worked as an independent consultant on a variety of projects related to social justice, equity, and cooperative development. She has a Master of Public Administration from the University of North Carolina at Chapel Hill and an undergraduate degree in Pan-African Studies from Barnard College, Columbia University. Mary Boudreau is the Executive Director for the Connecticut Oral Health Initiative, a statewide advocacy organization that works to establish oral health for all. Previously, Mary was the Executive Director for the Connecticut Dental Hygienists Association and served as an adjunct professor at the University of Bridgeport. As a registered dental hygienist, she has more than 15 years' experience in clinical practice, administration, advocacy, and education. Both Mary and Zuleika participated in our most recent Oral Health Learning Collaborative, Advancing Oral Health Equity, and we will hear more from them shortly about their organization's work. About the Center for Healthcare Strategies. CHCS was established in 1995 through a major grant from the Robert Wood Johnson Foundation to improve the underpinnings of the nation's healthcare safety net. Today, the mission of the Center for Healthcare Strategies, CHCS, is to find opportunities to improve the Medicaid delivery system so that all of its beneficiaries get the right care from the right providers at the right time. To achieve its mission, CHCS has worked with states, health plans, providers, consumer groups, and federal policymakers, focuses on 3 priority areas. 1, enhancing access to coverage and services. 2, advancing delivery system and payment reform. And 3, integrating services for people with complex needs. To give you a sense of the types of projects that we work on, here are a few national CHCS initiatives. Federally funded initiatives like the CMS Medicaid Health Homes TA project are marked with an asterisk. Zeroing in on CHCS Oral Health Initiative, the Center's portfolio to advance oral health care coverage, access, and quality for children and adults served by Medicaid dates back to the early 2000s. To that end, our current work through the Advancing Dental Access, Innovation, and Quality for Medicaid Enrolled Adults project includes direct technical assistance through learning collaboratives on topics like oral health equity, production of publications and tools like the Stakeholder Engagement Planning Tool to increase awareness and provide guidance on advancing oral health care access, and analyses of oral health utilization and expenditures among Medicaid-enrolled adults. Now we'll move into the overview of oral health equity. We'll start off with this illustration, which many of you have already seen, but still nicely depicts equity as it relates to equality. As you can see from the picture, equity results in equal outcomes. Everyone can see the game. This reflects a core principle of equity, which is fairness or justice. So what is health equity? Health equity is social justice in health, meaning no one has been denied the possibility to be healthy for belonging to a historically disadvantaged group. This concept is deeply intertwined with health disparities. In fact, You'll often hear the terms used interchangeably, but what's the difference? Health disparities are how we measure progress toward achieving health equity. According to the Centers for Disease Control and Prevention, health disparities are health differences closely linked to economic, social, or environmental disadvantage that adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based on characteristics that are historically linked to discrimination or exclusion. For example, among non-Hispanic Black adults, permanent tooth loss is highest, and untreated tooth decay is nearly twice as prevalent when compared to other ethnic groups. These are some key examples of oral health disparities in America. Considering disparities' historic roots in systemic exclusion, the factors that influence these disparities run deeply. Here's a short list based from the Kings County Equity Impact Review tool. I'll read just a few in the interest of time. Access to affordable and culturally appropriate health and human services, quality education, affordable, quality, and healthy housing, and early childhood development are all some factors that drive health disparities. Levels of bias. Considering that the concept of health equity is rooted in social justice, we have applied some relevant theoretical framework to isolate the various overlapping influencing factors. Here we've applied Race Forward's framework on racial justice to describe the levels of bias that contribute to health disparities. The two levels of bias, macro and micro, as depicted in this graphic, are defined by who or what they affect. Macro levels of bias, starting with structural bias, which is bias across institutions in society. It is the cumulative and compounded result of systematic privilege extended to some people based on race, gender, or other dimensions of identity. Examples of structural bias are often access-based, such as electronic applications to college, which are structurally biased towards those with access to the internet and computer technology. Institutional bias occurs within institutions. It is discriminatory treatment, unfair policies and practices, and inequitable opportunities and impacts based on race, gender, or other dimensions of identity. I often think of institutional bias as how structural bias is implemented. And carrying forward the example of electronic applications, an example of institutional bias would be the policy to instate electronic applications. Micro levels. Interpersonal bias occurs between individuals. This is how our personal beliefs affect interactions with others. The length of time most people will stop and speak with someone who they believe will give them money versus someone who they believe will rob them is an example of interpersonal bias. Internal bias lies within individuals. These are personal manifestations of bias that influence how we view ourselves and how we expect others to view us. You might recall from your own experience going on a job interview well prepared in your finest suit, expecting and anticipating even to be offered the position before even going on the interview. And that would be an example of positive internal bias. Addressing the levels takes different approaches as pictured here. You'll notice that the macro levels of bias can be addressed through macro interventions, like promoting values and implementing new policies. Micro levels of bias can be addressed through more individual interactions, like workforce training and individual counseling. In an effort to assist states with advancing oral health equity, CHCS launched a learning collaborative in January to support 5 teams with producing logic models and assessing the impact of their programs on oral health equity. Participating organizations hailed from Connecticut, Massachusetts, North Carolina, Pennsylvania, and South Carolina. We adapted tools from organizations like the Annie E. Casey Foundation and King County government to assess equitable impacts of programs. These analytic frameworks were used to guide the logic model development to ensure that the effects of program and policy interventions on disparate populations were considered to optimize the impact of these programs on all rather than a few. Leveraging these impact analysis frameworks, participants in our learning collaborative prepared program logic models to advance oral health equity, like the one pictured here. And each participant was asked to consider going from right to left, starting with impact. The impact their organizations would like to make on a particular identified health disparity, thinking through the populations affected, contributing factors, and micro, macro levels of bias. Moving to the left, short-term and long-term outcomes that would need to happen in order to make that impact. Targeted activities and outputs to achieve those outcomes and reduce the disparity gap, being mindful of whether the proposed activities may potentially expand other disparities. And then lastly, consider the resources available to their organizations in targeting disparate populations, like community-based organizations, faith-based organizations, grassroots, and other potential funding mechanisms to execute activities and produce the desired outputs. So now here we'll pause to respond to any submitted questions. Please remember to submit a question. You may click on the question mark icon located in the toolbar at the top of your screen. Okay. So we have one question just asking for some clarity around the levels of bias and how that might apply to health disparities and equity. Just to clarify, when looking at the levels of bias, the example provided was for an electronic application, and similarly in healthcare, electronic health records are another popular intervention for population health management and also increasing access to personal health information. However, in some low-income populations, they can also be biased against this access, so that if they don't have a computer or internet access readily, they can't log into the patient portals, schedule appointments, and access their personal medical records as someone who's more fortunate may be able to do. So that's an example of a structural level of bias in health. Okay, so now we can move on to the perspectives from the field, state approaches to advancing oral health equity. We'll start with North Carolina Oral Health Collaborative, so I'll turn it over to Zuleika.
Thank you, June, and I do want to start off by just offering a word of gratitude to June and to Stacy and the folks at the Center for Healthcare Strategies for this opportunity, both in the Learning Collaborative and to be able to speak to you all today. So yes, I'm 10 months into this position as the director of the North Carolina Oral Health Collaborative, and it has been a riveting 10 months, I must say. Oral health is a new issue area for me, and it has been sobering to discover the many disparities and inequities that exist within this area. So as you see on your screen, the purpose of the North Carolina Oral Health Collaborative is to convene diverse stakeholders to identify and resolve consumer-level and systemic barriers to good oral health, and to accelerate implementation of policies and practices that reduce oral health disparities and promote improved oral health for all North Carolinians. Put more simply, our work is about achieving oral health equity for all North Carolinians. Next slide. And our values are both a way of prioritizing our work, and it's our call to action. They express our underlying assumptions about what it will take to improve oral health for all North Carolinians. And I'll say that each of these has a longer explanation that could be available to you through our website, oralhealthnc.org. But what you see here is prevention, whole person care, of course equity, cultural competence, patient engagement, efficiency, and guided by science and evidence. Next slide. Our guiding principles are a compass for decision-making and provide a context about how the work needs to be done. And these are accountability, boldness, collaboration, commitment, and impact. Next slide. Now, this visual provides an overview of the NCOHC structure. The three focus areas on the top left reference our 3-year action plan, or our roadmap for the work that lies ahead. And this is a document that was collectively developed and has had many evolutions, and like any other good living document, we expect that it will continue to morph and adapt as this work unfolds. We know that rigidity is not a good playmate for creativity and innovation, so we try to stay open and flexible. One thing that I will note, that while the collaborative had strong representation from content experts, that is, folks working directly on issues related to oral health, what was missing was the voices of context experts. And for this reason, last month we launched our Capacity Building Mini Grants program, and this program is enabling us to partner with 7 community-based and intermediary organizations that already had some inclination either towards health equity or social justice, but this is our way of inviting them into the conversation about oral health equity and how this relates to their work. And we're excited about this aspect of our work because we understand fully that integrating the voices of the individuals that carry the heaviest burden of oral health disease is essential to our work. And this is just one of the many ways that we are bringing equity to life. While there's been a lot of talk about patient engagement or quote-unquote engaging those most directly impacted, it is a whole other world to operationalize these concepts, and not always easy, and can often be perceived as barriers, but essential nonetheless to the integrity of our work. And we have an upcoming spring convening this Friday, which we will be introducing for the first time simultaneous interpretation in our efforts to create an equitable space for the community-based advocates who are joining our work, whose dominant language is Spanish. And as an important side note, the theme of our convening this Friday is equity. We're bringing back the amazing folks at the Interaction Institute for Social Change to help us guide this conversation. Next slide. So, and the timing of this convening, the theme of the convening could not be any better because we've got our work cut out for us in North Carolina. Now, I'll start with the positive and say that there's been some truly impressive work around oral health in North Carolina. Our state is even a national model with the Into the Mouths of Babes program through our DHHS Division of Public Health Oral Health section. And it's an exemplary program focused on prevention and medical dental integration. And there is still ample room for improvement. So I've selected just 3 statistics for the purposes of this presentation. The 2 highlighted here speak to the limited number of providers within our state. North Carolina is 44th in the nation with only 48 dentists per 100,000 population. And there are still a few counties in our state that have 0 dentists. I believe it's 4. It is important to note that while there is a deficit of dentists, there is a surplus of hygienists, which in my simple mind begs the question, how can we better utilize all existing oral health providers to meet the needs in our communities, particularly our rural communities? And as most of you know, this is a loaded and complex question, and it is one that we are committed to grappling with. The other important statistic is the percentage of dentists participating in Medicaid child dental services in 2014, which, as you see, is only 27% in North Carolina compared to the 42% national average. Now, one of the top reasons that we hear for this low participation in Medicaid is the low reimbursement rates, which is a legitimate concern and one of the several policy priorities that we are also committed to researching more deeply for potential advocacy in 2017. But obviously, there's no point in educating folks on the importance of oral health and encouraging them to prioritize their children's oral health if there are no providers within their communities that are willing or able to provide care. Slide. Next slide, please. The other noteworthy statistic is around the percent of kindergartens who come to school with untreated decay. Now, this slide was created by one of our partners at the Blue Cross Blue Shield North Carolina Foundation, and it's much better with animation, but here it still gives us a sobering snapshot of our current reality. As you see, there's quite a difference. The top statistic is for white children in Orange County, which is a suburban county where the University of Chapel Hill is. Then we have the statistic for all children statewide, 15%, and 18% of Black children statewide. And 31% of children in Chowan and Hertford County, which are in the eastern or rural part of our state, come to school with untreated decay. And the most sobering of the statistics is that 44% of Hispanic children in Vance County, which is in the western part of our state, arrive at school with untreated decay. Now, this is particularly sobering because we know that this disparity is not unique to North Carolina. And because of this, engaging the Latino community is an integral part of addressing oral health disparities in our state and in our nation. For that reason, 3 of the 7 capacity building grantees that we've selected work directly with the Latino community. And I'm going to say that as a first-generation immigrant, my family has grappled firsthand with a lot of these inequities, and so it's work that I hold close to my heart. I'll also note here that through our partnerships with NC Child, which is our state's child advocacy organization, and Youth Empowered Solutions, we're creating an oral health equity primer that will contain these statistics and many more, and probably much prettier visuals. But unfortunately for you all, this webinar came before that work in progress was completed. Next slide. So, it is abundantly clear to us that addressing disparities such as these require holistic solutions and the brilliance of many to tackle. And that is exactly what we're co-creating with the North Carolina Oral Health Collaborative. I'm going to share these next 2 slides just briefly because I know they're dense and I don't want to bore you all with details. And I'll just highlight that this logic model is a combination of the work we did through the Advancing Oral Health Learning Collaborative and combined with our pre-existing action plan. You see on the left the resources and outputs. The middle column you see the 3 focus areas of our action plan and included within the long-term outcomes. What is not reflected here is that within each of these long-term outcomes there are short-term outcomes and corresponding activities. And at the end you see the impact that we're trying to have in North Carolina. Next slide. And so another way of looking at our comprehensive work is through a frame called the theory of change. While this particular piece of work is also still in progress, it offers a good visual synopsis of the overall work that we're trying to do with the collaborative. Theories of change represents beliefs about what is needed by the target population and what strategies will enable them to meet those needs. Again, this is just a powerful, colorful way of capturing the many different facets of the work that we're creating in North Carolina. Next slide. And fortunately, these slides will be available to you, and so you'll get to digest these more deeply, and of course I can be available to any of you if you have further questions. So the interconnection and valuing of other people's lived experience is essential to shifting the underlying power dynamics that have either created or exacerbated health disparities in the first place. If we say we're about systems change, then we must first understand why these inequities exist before we can co-create solutions to address them. The status quo is in place because it benefits somebody or multiple somebodies. If we are challenging the status quo because it is perpetuating an inequitable oral health landscape, then we need to be well prepared to grapple with the aftermath. In the words of Frederick Douglass, a power concedes nothing without a demand. It never did and it never will. And in my mind, it would be difficult to talk about equity without talking about power. And as a newcomer to the world of oral health, what has become quickly clear to me is that there is a tremendous power imbalance at the core of oral health disparities. For far too long, the conversation of oral health has been controlled by a relatively small but incredibly powerful group of individuals, typically small business owners, that have the primary imperative focused on increasing profit margins and ensuring the success of their business. And I believe this is an example of the structural and institutional bias that June alluded to early on in the presentation. And while this is understandable, it can conflict with the public health aspiration of increasing access to oral health services for all North Carolinians and focused efforts on prevention. A core purpose of the North Carolina Oral Health Collaborative is to be a space for honest, transparent conversations about these power imbalances so that we can harness the collective brilliance of many to generate solutions and to organize to demand change. This open, inclusive, intersectional approach has reinvigorated our work and has been welcomed by most. However, I'm sad to report that we have lost one key stakeholder along the way. On March 21st, the North Carolina Dental Society, which represents about 75% of private practice dentists in our state, decided to withdraw participation from the collaborative. And up until that point, the North Carolina Dental Society had been a strong member of our collaborative and of our leadership team. Specifically, the letter that they submitted to us cited concerns about the collaborative nature of our work and the pursuit of policy change, two tenets that are central to our vision and to our approach. And given the essential role that organized dentistry plays in bringing to life oral health equity, this is undoubtedly an unfortunate turn of events, and it is our hope that at some time in the near future, the North Carolina Dental Society will re-engage with us to deliver on our vision. However, this departure should not and will not overshadow the fact that we are now more committed than ever and emboldened to bring oral health equity to life in North Carolina. Next slide. And so what is the work that lies ahead for 2016, and how does this connect with oral health equity? As you can see from our action plan and from our logic model, it is our aspiration to address both macro and micro levels of bias. We will continue to grow and strengthen our network. This network, this collaborative, is only as strong as its membership, and goodness gracious, I'm pleased to announce that we have an impressive list that is growing more every day. We're going to be focusing on increasing public awareness, community engagement, and capacity building, because we know that an informed and engaged populace is a different kind of power to contend with. We are building the North Carolina Oral Health Agenda, which is intended to be a participatory process that will collectively determine the oral health policy priorities for North Carolina in 2017, and we're preparing for the 2017 Oral Health Legislative Day, which will be an opportunity to highlight oral health equity and bring attention to potential policy solutions. And we're so grateful for the support that we've received throughout the year in many different forms from the DentaQuest Foundation, and we are proud to be part of a regional and national network that understands oral health is a social justice issue, and that learning from each other is an essential ingredient for our success. And we are also very grateful to three of our state's health funders for their tremendous vote of confidence in our work and their investment in partnership to bring this life to work. And that is the Blue Cross Blue Shield Foundation, the Kate B. Reynolds Charitable Trust, and the Duke Endowment. Next slide shows my contact information. The next slide, there it is. Oh. And feel free to reach out to me if you have any questions or if you want to continue this conversation. Thank you again.
Thank you, Zuleika. At this time, again, we'll respond to some submitted questions. Please remember that to submit a question, just click on the question mark icon located in the toolbar at the top of your screen. We'll start first with a question that came in, I believe for me, but during Zuleika's presentation from Cynthia. Can you discuss more the direct technical assistance given to state Medicaid agencies? So to be specific, the Learning Collaborative was held with organizations based in the community and other oral health coalitions, not specifically state Medicaid agencies. However, the objective of the exercise to walk through the logic model and identify resources called out specific strategies for collaborating and partnering with Medicaid agencies, Medicaid officers, dental Medicaid officers, et cetera. So there was direct technical assistance that was very relevant to the particular health disparities that each organization identified. For the purpose of that exercise, we took that approach because the overall aim was to improve an impact on a population. So we really drilled down into a specific condition and a specific population and came up with strategies that were very deliberate on impacting those populations and those conditions. Moving on, we have another question from Martha, I believe for Zuleika. Who is the main provider to those with health disparities?
The main provider of care? Is that the question?
Yes.
Yeah, so we have a pretty strong network of safety net clinics, of FQHCs, and again, that small percentage of private practice dentists who do see Medicaid patients are the ones that are taking care of that segment of the population.
Okay. And another question from Mary, are the oral health disparities experienced by older adults addressed in the North Carolina Collaborative?
Indeed. I think that in some ways it would make our work easier to focus on children only because they're just so cute and easy to advocate for, and we also understand that oral health disparities impact people across the age spectrum. So our work does encompass adults, and particularly older adults. We know that there are growing disparities.
Okay, and related, another question from Linda. Would like to hear more about the work being done with long-term care patients and those in skilled nursing facilities.
Yeah, one of our partners who has been an inspiration to me in this work are the folks at Access Dental Care, who they're based in the central part of our state. But they, too, present a model in terms of taking a mobile dental clinic, basically packing up a van and traveling to different long-term care facilities and setting up a dental clinic within either the break room or the cafeteria and providing the care that is needed within those facilities. Access Dental Care has also been integral in advocating for some changes in terms of the standards for mobile units, because we also know that unfortunately there are some entities that are taking advantage of the system but not necessarily providing the care that is needed, and so that we want to support and highlight the good agents, the good players, and encourage the expansion and replication of their work, and then we also want to be sure to limit those that are not necessarily doing it for the good of community, we'll say.
Okay, a couple more questions. One came through, have you looked at the number of emergency ED visits at the hospital for dental concerns?
Yes, that's one of the statistics that we are including in our primer that is in development, and North Carolina has a very, very high rate. And so, yes, that is definitely part of our work in figuring out how we engage the hospital association in that work and other key stakeholders. We know that in particular in rural counties, when there are no other providers, where people end up is the emergency room. And so that is a major area for us to look at in the year to come.
Okay, just in the interest of time, we're going to proceed with the next presentation from Connecticut. I'd just like to just notify everyone that there will be a formal question and answer section at the end of this presentation. In addition to that, any questions we don't get around to during the course of this webinar will be posted for response. Okay, and now I'm going to turn it over to Mary.
Hello.
Hi, thanks.
So thank you, June, for inviting myself and the Connecticut Oral Health Initiative to present our work here in Connecticut on oral health equity, and also want to thank the Center for Healthcare Strategies for the training we received that led up to this webinar. And I want to welcome everyone to the webinar, and after listening to everything going on in North Carolina, I'm shocked that it's only 10 months, I think was what you told us, Zuleika. So that was wonderful. Just a little background on the Connecticut Oral Health Initiative. Our mission is focusing on oral health for all. We do that through advocacy, coalition building, and education. And the whole idea is try to promote oral health for everyone in the state. And so our main focus, as I said, is on advocacy. And as the executive director of this small nonprofit, which I've been here for 4 years, we try to focus on having a say both legislatively and with state agencies in making system changes. We are also part of an informal coalition, the Connecticut Coalition for Oral Health, which of course being the initiative, we get confused with being the coalition. But the coalition is more informal, and it is a group of many stakeholders who come together. And it's through there that oftentimes we are educating people on the coalition as to what are the system changes and how they can advocate those changes throughout the state. As we work to increase access to oral health, we do, oh, I'm not advancing the slides, am I? They're not going. Can I have help with advancing the slides?
Just one moment, Mary. We'll advance.
Okay, because I'm pressing the buttons and notice they did not enhance. Okay. So that's where our mission is stated, and our goal is to help enhance that mission. And now we'll go on to the next slide. And so our origins is that the Connecticut Oral Health Initiative actually started off with a committee called the Oral Health 2000 out of the Connecticut State Dental Association. And they changed to Oral Health 2010, but at the same time they started to notice that they needed to develop their own identity. This group needed to work and accomplish things that were not always possible within the Dental Association. And so they did incorporate and found funding in 2001. And at that time, there was a lawsuit, which many of these people were involved in, the Carr versus Wilson-Coker lawsuit, which was to improve the number of providers for dental Medicaid in the state. At the time in 1999, Connecticut only had not even 300 dental Medicaid providers. We have almost 3,000 dentists at the time in the state, and so access to care was very difficult for anyone who was covered by Medicaid. Now, the outcome of the lawsuit was a settlement in which there was a couple of things that happened, and one was that the dental Medicaid reimbursement rates were improved. They were changed to being 70% of the usual fees of 2005, and they went into effect in 2008. And that was an increase of 73% to 208% of the previous fees. So some of them went up, on the average, they went up over 100% for what they were. Also, we improved the administration of the service. We were working with HMOs, and we went to one ASO, an Accountable Service Organization, which we've now gone to for medical, behavioral health, transportation, and in the state. And that made the administration much easier for the dental practices, where they would sometimes have to wait 6 and 18, up to 18 months to receive payment. It now works very much like an insurance company, a private insurer, and oftentimes even better than a private insurer in turning around payments to the offices. So COHI played a major role once they came into existence with working with the implementation of the settlement. And at this point, we can proudly say that we have over 2,000 dentists who are receiving patients who are covered by Medicaid, which is about 2/3 of the dentists practicing in the state at this time. And you will see in slides in a moment that will show where we are, the successes we have, and why now with the state budget we have a fight in our hands to maintain the Medicaid program as it stands. So on to the next slide. You'll see that we are talking about some populations that need more focus than others, and that is your Black and Hispanic families, so that's children and adults, our low-income and uninsured adults, our older adults, and for the most part, it's mostly urban dwelling, though rural does come into play, even in our little state of Connecticut, in our two northwest corner and on the east side of the state. On to the next slide. So here's some of the things that have, will give you a little background. One is that 1 out of 5 residents in the state of Connecticut are presently covered by Husky, which is the name of our Medicaid program. And when you look at the chart that shows the children who have dental caries experience, this was from a Department of Public Health Every Smile Counts survey that was completed in 2011 and published in 2012. And you can see that our Hispanic population, as with, I believe, every state or most states in the country, do have the highest rate of decay experience in kindergarten and 3rd grade. Non-Hispanic blacks are very close in that high rate of dental caries as compared to our white population. Going on to the next slide, I want to show you the graph, and I know the print is small, but hopefully you can read it, is that it does show that when the effect of this new Medicaid plan went into effect in 2008 and up to 2011, and we don't have a chart that I could easily show you showing the advancements that have happened in 2012 to 14. But you can see that, again, the top line is the Hispanic population, though they did have a nice increase in the number of people receiving, utilizing the Husky A program, which is, again, our Medicaid program for families. And the lowest line you can see is our Black non-Hispanic population. The disparity gap between those two started off at 9.4 percentage points and went up to 7.9 percentage point difference. And that gap continues to decrease over the next couple of years. And on to the next graph, which will be the last graph I'm showing you, so you don't have to look at lots of graphs here, is we have a same type of growth in the parent population receiving any dental care. We had only 32%, and we're up to 50%, which is really close to the national average for parents with private insurers, not just with Medicaid. You can also, if you'll notice, that the preventive care keeps rising each year. And the main reason the preventive care is rising is because a lot of people have gone into treatment and now are in that preventive care portion of their oral health. And so that helps, obviously, with our residents of Connecticut. We like them to be in a preventive mode and getting treatment when they need it and not going to emergency rooms and such, which also leads towards our state legislators, and our governor has complemented the dental Medicaid program because of the cost to the state out of the state budget is actually decreasing, even though every year we've had an increase in the number of people who are covered by Husky. But the per person per month rates have gone down. The other thing that, because of that lawsuit and because we were able to get so many dentists to sign up to take Medicaid patients, that at this point in every part of the state, we have at least 2 Medicaid-accepting dentists within 10 miles of anyone's home in over 90% of the state. And we just have in 2 of our corners where there's very few dentists, and that it is 2 within 15 miles. The vast majority of children covered by Medicaid have a dentist within 1 mile of their home that accept Medicaid. So access has certainly been an increase, and utilization is where our focus is been the last year or 2, is really trying to get more people into the dental offices and addressing some of their barriers, which are on the next slide, please. The barriers are not ones that I would think anyone would find different from their own areas. We have many families who cannot afford it. That's where Medicaid has come in, where we have had a restructuring of a Medicaid program where we had done an expansion to over 200% of the federal poverty level. It has now been decreased, to 155%. And those people lost dental insurance even if they did sign up for the healthcare exchange, because dental is not included. We did succeed, as a little side note, in the healthcare plans, the quality health plans through our health exchange for children are automatically receive dental insurance. The dental insurance is included in or embedded into their health plans. A parent doesn't even need to check off another box saying they want dental insurance. They automatically receive it, which is very fortunate for our children through the age of 18. Lack of continuous coverage, we have found in studies done in the state that once, and we've seen them nationally, where people will be on and off insurance for dental insurance. They tend to, once they lose dental insurance, they don't go to the dentist as often, and even when they regain coverage, they tend not to go back to the dentist until it's an emergency. So not having continuous coverage is definitely a problem. Of course, for our older adults, we know Medicare does not cover dental. We have cultural and linguistic barriers. At this point in time, we have 89 languages being spoken in the state of Connecticut in homes. And so we really need to look at these cultural and linguistic barriers in order to help professionals help our citizens. And then oral health education and some of the other problems that are listed there. I won't go into all of them because you recognize them all as ones that you see. So going on to the next slide, what we've currently have been working on or have recently worked on is starting with the collaboration with state agencies. As I said, COHI works to do system changes both with the law, with legislature, and with state agencies. With the Department of Public Health, there's multiple programs happening. I just listed two of them here. One is that they have developed a state health improvement plan called Healthy Connecticut 2020. And what we worked on was getting oral health as one of the chronic diseases of focus in the plan. And then we further worked to make it as one of the priority focus areas for 2016 and 2017. And we mainly were successful in that by talking about how oral health affects overall health. So when we're talking about oral health, as you know, oral health can have an effect on your heart, on diabetes, on obesity, on asthma, on respiratory diseases, with pregnant women, on low birth outcomes. And so we were able to strategize or put in strategies in many of these other diseases and make sure that they are also looking at what is happening in the mouth. We also, with the Department of Public Health, which I didn't mention here, is we just had our community water fluoridation statute amended this year to match the new U.S. Department of Health and Human Services optimal level of fluoride. We, in our state, require all water systems that serve over 20,000 people must add fluoride or control the amount of fluoride in the water. And what we went to was from a 0.8 to 1.2 parts per million to having the optimal level according to the U.S. Department of Health and Human Services. And that bill was just signed by our governor last Friday, so we're very delighted about that. And we also have a dental sealant program going on in the state, really focusing on our schools and school-related programs in order to reach those children who are not getting sealants through regular visits to the dentist, be they covered by Medicaid or they don't have any dental insurance at all. Not to go through this whole list, but basically what we're trying to do with working with the Department of Social Services, with the person-centered medical homes, with the state innovation model, which is part of the Affordable Care Act, in trying to hit that triple aim of improving population health, lowering costs, and improving quality of care. We're trying to really make oral health be part of health. so that we can impact people's lives. And so we're trying to get it into as many medical systems as we can. So moving on to the next slide. The next thing we started to work on, or the other thing that we work on, is our legislative advocacy. And though we had 19 bills that we were following this year and putting in testimony to, I put on here just the few that were took up most of our efforts. Our legislation this year was working with the state budget, trying to save Medicaid. I'll say more on that in just a moment. The statute on community water fluoridation I just talked about. We also, along with the Commission on Health Equity, asked the legislature, and they did raise a bill on requiring cultural competency continuing education for every renewal licensing for dental hygienists. It is also partially required already for dentists, but now we are trying to get it in for dental hygienists. It did pass the House, but we did have our short session this year of our legislation session, and then we also had big problems with our state budget, and so it never did make it to the floor of the Senate, but we have been promised it will make it to the floor of the Senate next year and will be passed next year. So we're excited to see that happen next year, even if it didn't happen this year. We were also fighting cuts to our community health centers and our school-based health centers, because if funding from the Department of Public Health and Department of Social Services, our Department of Social Services is our Medicaid, if that funding ended, many of them would not be able to provide services to people who are uninsured. They'd still be able to cover people who are covered by Medicaid, but not for those who have no insurance at all and no way of paying for dental care. With the legislation on saving Medicaid, a number of different proposals came out of the governor's office and the legislature. One was starting with adult dental. They were talking about cutting the number of Husky A parents eligibility, trying to reduce the number of people who would be eligible. And of course, as I mentioned, if they ended up going onto our health exchange, they would lose dental coverage. Another one was trying to cut orthodontic coverage. We use the Saltzman scale here to determine the severity of their orthodontic needs, and they raised it last year from 24 to 26 points, and they wanted this year to raise it to 29. And for those of you who know about the Saltzman scale, by the time someone gets to 29, we're not talking cosmetic, and that was the argument they were using. We were doing cosmetic ortho on children. And instead, we really fought for making sure that those children who need it for medical, psychological, and social reasons were able to get the treatment they needed. We were successful so far on all of those issues to get them off the table. What we were not unsuccessful in doing is maintaining the reimbursement rates. With the success our program's been showing, we have been saying it's time to raise the rates, since they were based on 2005 and it's now 2016. But they have talked about reducing the reimbursement rates by 10%. Some will say we're successful because right now what's on the table is a 5% reduction in the children's Medicaid provider reimbursement rates, but 5% to us is still going to impact the number of dental providers who will continue taking the same number of Medicaid patients, and where we're trying to get more Medicaid patients in. The last thing we want to do is lose some dental providers, or at least that chair time in their offices. So that is still on the table. Our regular session ended on May 4th, but they did not come to agreement on the state budget, and it will be voted on May 12th. So we're still trying to make that change. If you could go to the next slide. I just want to show that we did come up with a logic model to show what we were working on for just the Medicaid alone. as I said, we had many different things we were focusing on. But to maintain access to dental care for low-income and minority families, our big focus had to be on Medicaid. And so we did want to, maintain the current utilization rate as one of our long terms, as listed in front of you, list of dental and Medicaid successes as developed and disseminated. We use these very successfully with our legislators, saying this program's working, don't hurt it. And got even the governor to come out and say the Medicaid plan is working great, including the dental Medicaid, are great success stories. And but somehow the message got lost that dental Medicaid is part of Medicaid because they made no cuts to Medicaid other than the dental, or no proposed cuts. So in working through our strategies, I used the logic model successfully for the first time. I've never been one who could set up a logic model, and through the training I got, I set up one for cultural competency, and then I set up this one for the webinar program we were in. But now for this one, for the strategy for Medicaid, I sat down and in like 45 minutes I had the whole thing complete. And it served as a great timeline for us. We were able to use this and say, we've gotten this step done, we've gotten this outcome, we have it, and was able to move forward. And so we're going to go to the next slide, which I do want to say that what I found the logic model worked for us is really giving us the focus on what is that impact we want to make, how do we get there, looking at the activities, deciding through prioritization which ones we should be doing, remembering that we need to stay in contact with all of our resources that we had listed on there, making sure they had the materials they needed, the education they needed, and that they were following through with contacting our legislators and governor's office. And so it really worked as a working model for us to look at and almost like a checklist to use. And so overall, we think many people tell us we were very successful in fighting all the cuts they were going to make to dental Medicaid. I'm still not happy with the 5%, but we'll keep moving that on. And the last thing I want to say with working with the model is, I sort of mentioned it, making sure that all of our resources, our coalition building, that we worked with all these advocates, and we really pulled in a lot of non-oral health advocates. And so when the legislators would talk to me, they said, yes, we heard this from, and they would mention other people who are not in the dental field, and it seemed to make a stronger impact than when we spoke, who are from the dental field. So that was really good to hear that that effort that we made really did work out for us. And so we can go on to that last slide, which is for my contact information there. You have it all. And I'll certainly continue any conversations with you that you would like to continue after this webinar at your leisure by contacting me at that phone number or email address. And I guess we're time now for some questions.
Thanks, Mary. Yeah, I think we have time for one question. There have been several that have come through, so I'd just like to restate again that any questions we haven't responded to throughout the course of this webinar, we will post on the landing page of the webinar where you registered. So the question that we have that came through from Christine is, how did Connecticut determine that these particular social determinants were the causes of disparity?
It actually was mostly through the Coalition on Oral Health. They first joined together as the Coalition for Oral Health Planning and developed our state oral health plan back about 10 years ago. And it was through collaborative discussions. I can't say it was through research. Some of it was definitely based on research that people were able to bring to the table, but these were the ones that were recognized as the ones that had the most impact. Not that the list wasn't longer, but these had the most impact.
Okay, great. I would like to move on to the next slide, the resources. Thank you. Here are a list of resources that we leveraged in the Learning Collaborative. A few questions have come through about the training and related to what materials were referenced in both Connecticut and North Carolina's exercise through the Learning Collaborative. We relied quite a bit on some background materials related to oral health disparities, building logic models, and impact assessments. In fact, using a framework from the Society of Practitioners on Health Impact Assessment to apply equity metrics. I would just like to, in closing, thank the DentaQuest Foundation for their support, Mary and Zuleika, our presenters, for sharing their experiences, and all of the participants who are on the line, thank you for attending. As a reminder, the webinar will be made publicly available on chcs.org, and an evaluation of the webinar will pop up when we close. We appreciate your feedback. Take care, everyone.